In addition to the Institute of Medicine report that was dealing with To Err is Human, there's also several others that have been put out dealing with quality and safety and different things. And this one here is called Crossing the Quality Chasm. And as a result of this, it recommended that Congress establish a healthcare quality innovation fund that was set aside money to support projects that really looked at aiming in organizations to have safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. So the 6 aims are very important to know because you're going to see that focus in healthcare organizations around those aims. And they're all things we'd all want in healthcare anyway. We want to have a safe environment for patients and workers. We want to have effectiveness in what we do. We strive to have patient-centered care. We want things to be timely to the degree that we can and have environments that are conducive to being able to be timely, as well as efficient at what we do. And then really driving that equity of care. And if I come in with the same kind of illness or problem, that I'm kind of getting the same key measures done for me that the next person is, so that I have the best chance of healing as well. And then, the other part was that they wanted to support projects that had substantial improvement in quality for high priority conditions that were identified in terms of the biggest problems and the biggest errors that were occurring in healthcare at the time. Another Institute of Medicine report that was called Leadership by Example was the third in a series of reports. And what this report reported on and its major findings were lack of consistency in performance measure requirements, meaning that within an agency or within multiple agencies, there weren't really good measurements set up that were precise, for one thing. They maybe at one time measured something a certain way, and at a different department they measured it a different way, or just some areas measured processes or problems or indicators of performance, whereas others weren't held responsible to do that. Again, programs were not using standardized measures that were all the same. There was really no conceptual framework that guided the performance of doing this kind of work. So even though they may have said in their quality plans back in the 1990s that they were using the Deming model or they were using the Juran method, when they looked down into what was really occurring in terms of quality or how was that being led in an organization, they really weren't doing what the framework said. I mean, there was not a connection between what was on paper and what was actually happening in practice. They also found Medicare, Medicaid, and the state children's health insurance program had a big lack of computer-based clinical data. And so not having enough data or not having the same kind of data measures and things really created an issue where you couldn't tell exactly about the quality from pulling information in a way that was meaningful. And then lack of commitment to transparency and openly sharing information on safety and quality. So leaders knew that there were errors, knew there were problems. They never really interacted with their consumers. They didn't post reports. They didn't have this information available to staff to where they really understood how we've been doing or trending. And that was a huge problem because, staff awareness of where we are is half the battle of trying to affect some change and improvement. So again, it was more a leadership mindset was secrecy on any quality problems that they had instead of being forthright about it. So, what are the implications of, a lot of this information? We as leaders must adopt and be adopting and nurture a continuous quality culture within an organization. We must have an organizational vision that clearly depicts what the organization is striving to accomplish. And just like you all did mission and vision statements, if you're striving to really accomplish something major, you should have that vision and it should be very clear, and everybody in the organization should be centered around that vision to ensure that it occurs. We must also communicate effectively with internal and external stakeholders, really engaging them in the process, and we must be designing core value statements that become part of the organizational culture. So these are all things that we kind of have already discussed as part of you working on a mission, vision, and values plan. But while that is a wonderful leadership plan, it meets the basic standards for making your organization or your department or whatever division it is to have a much more effective chance at delivering on quality on the end of it all. So nurse managers have what's called a healthcare quality toolbox. And this really gets into quality management in the measurement standpoint and analysis standpoint. And I'm going to provide you in class a nice little online PDF form that has a lot of these forms in there that you guys will select and pick which kind of a analysis method for the problem that you're giving would really depict this the best. How would you show the data that you're managing or that you're trying to grasp where the problem is? Do you need to do some kind of a cause and effect diagram? Do you need to do a control chart? Do you need to do a flow chart to kind of map out a process, a Pareto chart, a scatter diagram? And then there are other things that we use also, like a root cause analysis, a failure modes effects analysis. And so I'm going to show you some additional ones as well that you can select as part of your team to kind of work through a problem with. And this won't be, an all-day event today, but in reality, if you were in a total quality management workshop, you would probably be spending several days at mastering each one of these tools in team settings and multiple problems and that kind of thing. So this is just more of a draft, try it and see what's out there. But I do want you to be familiar with all the different types of charts and diagrams and methods, because that's really the heart of being able to apply some of this quality management in practice. So you may see a data collection sheet where you're giving by your nurse manager, or maybe if you're doing charge, you have a responsibility later on where you have to go physically around the unit and you've got to inspect, let's say, to see whether your IV tubings were changed and labeled properly, or your IV sites are in date, or maybe it's to go and check skin condition on people one day, and so in some units you will have an actual person or position that kind of is associated with doing data collection, but more often, because of this focus of really getting many more people at the bedside engaged, you're going to often have this rotated responsibility around to do it, and you may be given some time out of staffing to do part of that and turn it in. And so that kind of ensures that it's everybody's kind of engaged at looking at the same thing. A control chart is just kind of like a run chart that's going to show you like what percentage were we running on compliance with a particular standard over several time periods, whether that's you're measuring it weekly, you're measuring it monthly, or you're looking at it on an ongoing basis, but stepwise, you're comparing generally week to week or month to month. How are we doing? And you're looking at, did we do worse or did we do better? Are we, gradually improving? But over time, you can, kind of tell more, is this just a little bit of normal variation along the median and we're not really changing much, which might be good if you're at a good number. And then, but when do you drop down too low and you have a threshold for, oh, we've dropped too low. We really need to, this wasn't just a normal thing. We dropped a couple of standard deviations below the median. Then we need to be up and considering some, doing some digging in what happened, what's the problem, what went wrong, what do we need to fix, maybe a new process was put in place or something that has affected or influenced this change in your run rate. Another thing that people will look at in terms of a process, like you're trying to figure out like where in the medication administration process could there have been a problem. So, you would sit down with that process, whatever it is. Maybe it's the discharge process for patients. And you start out and you look at what equipment did we have to have, what policies were in place, what was the environment like, what were some of the causes that could have led to an undesired outcome, a poor result, or poor effect. And then through that, maybe some of those are all working pretty well, but you kind of through that decide which ones of these really are having the most negative influence, and then you kind of do your actions or your changes in the process around where can we make modifications and improve this the most. Sometimes you have a detailed flow chart, and we've looked at this in terms of using algorithms, which is another term for this. But you're looking at, what are all the steps in a process? Like where is a decision being delayed, or at what point is something really getting halted, so that you're starting at one point in a process and your end at the other. So it's just one other way to kind of flow chart a process and figure out where are the delays occurring, where are problems most likely to occur. Maybe a decision is required, for example, by a specific position, like a social worker, for example, and if your department or your hospital only has social workers during the week, then obviously you're going to have a significant delay, because in that particular process you're looking at, if a social worker decision was required for that. So it's just an example of another way to look at a process. Pareto chart or Pareto chart kind of looks at the frequency of something occurring in terms of causal effects or factors. And so which one is your biggest problem that's causing the overall outcome? So that's another way you can analyze the significance of causal factors. Then a scatter diagram is always good when you're looking at something that's time related. You're looking at the average number of falls, but you're also looking at, are there any things in terms of time of day or day of the week, or, certain things that might give you an idea of when there's more likelihood for a problem or an event to occur. So we know that hospitals are accredited by the Joint Commission. This is a voluntary accreditation program. We've talked about that before. Joint Commission does conduct surveys on an unannounced basis, but generally you are surveyed every 3 years, close to that, as long as you're doing okay on everything. The Joint Commission also has an OREX program for many years now, where hospitals are required to enter data. And then CMS has a wide variety of other entities of collecting data as